Hi guys, welcome to the first episode of Ortho Study Tool. My name's Tony DeBarno, upcoming orthopedic surgery resident. Um, I wanted to create this channel to help auditioning medical students and fellow residents study quickly, efficiently, uh, refresh their memory on some information. I'm going to be posting videos every day like this, both to help myself study and also to make things easier in case you guys want to, just listen to some relevant material instead of sitting down and reading at the end of the day when you're tired. So hopefully this helps. Uh, let's get started. Today we're talking about ankle fractures. All right, so just a quick introduction. We're looking at AP and lateral radiographs of the ankle. We have the tibia, fibula, talus. Those are the main bones that we're going to be focusing on when it comes to ankle fractures. Other soft tissue structures like the deltoid ligament, which attaches to the medial malleolus, the syndesmosis, which is comprised of the interosseous membrane, the anterior inferior tibiofibular ligament, posterior inferior tibiofibular ligament, and the oblique tibiofibular ligament. Those are big structures that we're going to be paying attention to. All right, so some common imaging modalities or some common imaging done on the ankle. Usually you're going to see AP, lateral, and mortise. Your mortise view is view of the ankle with 15 degrees internal rotation, give or take. It allows you to visualize medial clear space widening. Anything greater than 4 to 5 millimeters is concerning for deltoid ligament disruption, which is essentially a bimalleolar equivalent fracture. Instead of having a fracture through the medial malleolus, you have instability because the deltoid ligament is disrupted. So that's why this mortise view is really important. It helps us visualize that, and it also helps us better visualize the syndesmosis, and we'll get into some of the measurements that help us assess syndesmotic integrity. Additionally, there's the external stress view, which is basically 15 degrees of external rotation, done a lot of times intraoperatively, helps assess syndesmotic stability as well. One thing to note, gravity views with the ankle hanging with gravity are essentially equivalent to an external rotation stress view, and it's more humane. You're not going to be inflicting as much pain on the patient, so that's a good alternative. So imaging continued. These are radiographic signs of syndesmotic injury. As I mentioned before, your mortise view will help on a lot of these to assess if there's any syndesmotic injury. So on your AP view, less than 6 millimeters of tibiofibular overlap is concerning for syndesmotic injury. So what does that mean? If we go back here, let's get a better AP view. If we go back here, you can see you have tibiofibular overlap. The tibia is overlapping the fibula. Normal is if you have greater than 6 millimeters. So if you're seeing less than 6 millimeters, the syndesmosis is potentially disrupted. You want to get additional images, and the patient may require operative fixation to stabilize the syndesmosis. All right, so let's go back. So that's on the AP. If you're looking at tibiofibular overlap on your mortise view, less than 1 millimeter is concerning for syndesmotic injury. So again, what does that mean? You can see on these mortise views, you naturally, well, this isn't your mortise, you naturally have less tibiofibular overlap. This should be overlapping the tibia in this case, so you have less than 1 millimeter of overlap here. So this patient probably has a syndesmotic injury, and then we'll get back to this in a second, but there's also increased medial clear space on that radiograph. So as I was saying, greater than 4 to 5 millimeters of medial clear space, depending on what sources you look at on mortise or stress views, is concerning for syndesmotic injury and deltoid ligament disruption. So if you look at this, I don't, have any tools to measure this, but just eyeballing it, it looks like there's more than 4 to 5 millimeters of medial clear space. Here, a lot harder to tell. This is your stress view, so likely, borderline here, probably a little bit more to 4 to 5 millimeters. So your deltoid ligament, which is attached in your medial malleolus, is likely disrupted, and your concern for syndesmotic injury is increased. Finally, another way you can assess syndesmotic injury is by looking at tibiofibular clear space. I like to think of this as basically the opposite of tibiofibular overlap. If you have a clear space, you don't have overlap. And it's not surprising that greater than 6 millimeters is concerning for syndesmotic injury. Some key differences between overlap and clear space are these should be less than 6 on both AP and mortise. And accurate measurement is taken 1 centimeter above the joint line. So if we're looking at this, 1 centimeter above the joint line, you go 1 centimeter up from here, and then you measure the clear space. I'm not sure if that's around here, but you can see this is probably greater than 6 millimeters of clear space. So again, likely a syndesmotic injury here. The angle on this also makes it look like there's less, because the incisura fibularis, which is where the fibula usually sits, is kind of concave, and so you're seeing the posterior portion of that. Some other radiographic considerations and helpful measurements are your talocrural angle. Greater than 83 degrees indicates fibular shortening. That's important because whenever you're either reducing or definitively fixing the fibula, you want to reestablish length, rotation, and alignment. So shortening is concerning for inadequate reduction. So let's look at what this actually is and how to measure it. So if we go back here, your talocrural angle is the angle created by drawing a line parallel to the anatomic axis of the tibia and then intersecting that line with a line that is drawn through the tips of the malleoli. So you'll have one line here connecting the malleoli. You'll have a second line bisecting it. And the angle you're looking at is the angle between those two on the side of the malleolus. Okay? So you can imagine if this was shortened, this tip would connect up here instead of down here. So now you have a line that's like this, and it's being bisected by this line. So instead of being, around 82, 83 degrees, that line is now 90 degrees, and that gives you an indication that this fibula is shortened. All right. Some other signs that may indicate a posterior malleolus fracture, which is where your posterior inferior tibiofibular ligament attaches, is the double contour sign. Another sign indicating posterior malleolus fracture is the Misty Mountain sign. I could not find any great examples of those that were open source, so I'll just try to describe those for you guys here. So those would be on like an AP radiograph. The double contour sign, you would see the cortex on the medial portion of the tibia and medial malleolus here, and then behind that you'd see this second contour, and that would be concerning for a posterior malleolus fracture. That's your double contour sign. Another sign is the Misty Mountain sign, and that would be whenever you see translucent lines in this area that are also potentially indicating a posterior malleolus fracture. So what is your posterior malleolus? On a lateral radiograph, you can see your fibulas here, and then if you look behind it, you have this outline here. This is your posterior malleolus, portion of your tibia that kind of stabilizes posteriorly and where the posterior inferior tibial ligament attaches. All right. So let's talk about classifications now. The two main classifications that I was really asked questions about as a auditioning student and that are referenced a lot for their usefulness, understanding the mechanism of injury, are the Logge-Hansen classification and the Danis-Weber classification. The Logge-Hansen classification describes ankle fractures in terms of the initial foot position, either supination or pronation, and the direction of force applied to that foot position. So you can have either adduction forces, external rotation forces, abduction forces, and again, external rotation forces. So those four combinations are the patterns that are described. We'll look at those in a little bit more detail because there are progressions of injury associated with each one. The Danis-Weber classification is very useful in assessing how much syndesmotic injury you would suspect. And also, if you understand this classification, it can give you some clues as to what type of injury mechanism you're looking at from this perspective. In Danis-Weber, your type A is infrasyndesmotic, B is transsyndesmotic, and C is suprasyndesmotic. So what does that mean? Let's go back. Your syndesmosis starts where your anterior and posterior inferior tibiofibular ligaments are, and then your interosseous membrane extends upward the full length of the tibia and fibula. But it starts right around here. So A, infrasyndesmotic, would be at this level. B, transsyndesmotic, would be at this level. And C, suprasyndesmotic, would be up here and above. All right. So let's look a little bit more at the subtypes of it, the types of Logge-Hansen injuries. So in supination adduction injuries, the progression of injury starts with first a talofibular sprain or distal fibular avulsion. So in this image, this is the best image I could find that was open source of a supination adduction injury. You're not really seeing a distal fibular avulsion. If you were, you'd see like a transverse fracture line right around here below the level of the syndesmosis. Supination, adduction injuries are Danis-Weber A infrasyndesmotic traditionally. And as that supinated foot experiences that adduction force coming across, the soft tissues come under tension on the lateral malleolus, causing the fracture or spraining the ligaments. And then the forces continue medially and upward, and you end up with either a vertical medial malleolus fracture, which is what you see here, and potentially impaction of the anteromedial distal tibia, which you also see here. So the talus impacts on the tibial plafond anteromedially, causing impaction. This needs to be addressed surgically. It is something that if it's not addressed can cause poor outcomes. Next, we have supination external rotation. So the foot position is the same, but the force now is different. You have a external rotation force. So you have a supinated foot. Where does the force start? It starts at the level of the anterior tibiofibular ligament. So right here. That's the first structure to be damaged. Then it progresses and it sweeps around external rotation and causes a short oblique fibula fracture at the level of the syndesmosis. So as we were saying, the tibiofibular ligament is right here, damaged. Then you get your short oblique fibula fracture at the level of the syndesmosis. And a key thing to note is this is antero-inferior to postero-superior. You'll see later on the direction is opposite in pronation external rotation. But for now, let's focus on supination external rotation. After the fibula fracture occurs, the force continues around and you end up with either a posterior tibiofibular ligament rupture or an avulsion of the posterior malleolus. Why is this important? If you progress this far in the fracture, you have one malleolus involved, you have disrupted the syndesmosis on both sides. Your syndesmosis is weakest in AP dimensions, so you're going to have syndesmotic instability, and potentially you have it's either a bimalleolar or bimalleolar equivalent fracture at this point. In this type of injury, if the force continues all the way around, you may end up with either a medial malleolus transverse fracture or disruption of the deltoid ligament. And if all four of these things have occurred, you end up with a trimalleolar or trimalleolar equivalent fracture. Very unstable. Traditionally, external rotation forces that progress all the way around result in some of the more unstable ankle fractures. So medial malleolus transverse fracture results from tension being put on the deltoid ligament. The deltoid ligament either gives out or you get a little transverse or avulsion fracture of the medial malleolus. In this case, it looks like maybe a small piece was avulsed and the deltoid ligament was disrupted here. And you can see a little bit of medial clear space. Next, we're going to look at pronation abduction type of injuries. So in contrast to the previous two, your foot starts out pronated, and then you have an abduction force that is introduced. So the force is going to push the foot this way, and it's not surprising that you see the talus over here. This is a fractured dislocation. It starts on the medial malleolus. You end up with a transverse fracture like you see here, or again, disruption of the deltoid ligament. It continues across. You lose the integrity of the anterior tibiofibular ligament. And then if it progresses all the way up, you end up with a transverse or comminuted fracture of the fibula above the level of the syndesmosis, which is exactly what you see here. So the force went like this, broke off this piece in the medial malleolus, disrupted the anterior tibiofibular ligament, and caused a comminuted fracture of the distal third of the fibula above the level of the syndesmosis. So this is a Danis-Weber C type fracture. If we go back here and look at this, this is a B, transsyndesmotic. We go back here, we don't have a fracture. Traditionally it would be here, and this would be a Danis A. Okay, finally we have the pronation external rotation type of mechanism. Again, the foot starts out in pronation and it is externally rotated. So the force starts here and rotates around. The first thing to go is your medial malleolus. Again, transverse fracture or disruption of the deltoid ligament. Second thing to go is the anterior tibiofibular ligament. It progresses upward and causes a lateral short oblique spiral fracture of the fibula. This time it's opposite, as I said before, antero-superior to postero-inferior. And the difference between a supination external rotation, in addition to this difference, is it occurs above the level of the joint. You can see it's above the level of the joint. The forces can travel all the way up the interosseous membrane in injuries like these and fracture the proximal fibula as well, and that's something that you need to pay attention to. Those are known as Maisonneuve fractures. In any ankle fracture, you want to look out for those, but particularly anything with an external rotation mechanism or anything starting out in pronation, because those forces are more likely to travel up the interosseous membrane. Finally, after the fibula is fractured above the level of the joint, it travels all the way around and you end up with a posterior tibiofibular ligament rupture or avulsion or a posterior malleolus fracture. So again, these external rotation injuries, if they travel all the way around, you end up with a trimalleolar or trimalleolar equivalent fracture, which is highly unstable. So let's discuss generally treatment options. I don't want to focus too much on this. I want this to be a basic overview, and then we can discuss in more detail in a later video specific ways to fix specific types of injuries. But generally, your two treatment options are either non-operative or operative, and these are some indications that you want to pay attention to. So if you go the non-operative route, you're going to have the patient stay in a short leg walking cast or boot, and you would do this in isolated non-displaced is the key, medial malleolus fractures or tip avulsions. Isolated lateral malleolus fractures with less than 3 millimeters of displacement and no talar shift. So you don't want to see the talus, shifted all the way out here like that. Bimalleolar equivalent or bimalleolar fractures, if the patient's very old, non-ambulatory, and unable to undergo surgical intervention. Otherwise, any other bimalleolar fracture most likely needs surgery. And finally, if you have a mild posterior malleolus fracture with less than 25% joint involvement or less than 2 millimeters step off. This is a question I've been asked before as an auditioning student. It's good to know, and it applies in reverse to operative treatment, but we'll get to that. So operative treatment should be undergone anytime you have significant talar displacement. The reason why is even small amounts of talar displacement result in significant surface area reductions in joint surface contact. So you end up with a lot of bone-on-bone contact and the potential for, poor outcomes, and arthritis increases drastically. Additionally, any displaced fracture, significantly displaced fracture of the medial mal or the lateral mal, it likely requires operative intervention. Bimalleolar fractures and bimalleolar equivalent fractures in people who are able to undergo surgery and who have the potential to be walking around a lot should have surgery. Again, this is the opposite of this. Greater than 25% of joint involvement or 2 millimeter step off requires surgery. Bosworth fracture dislocations require surgery. We haven't talked about those. That is a fracture dislocation of the ankle where the fibula is dislocated posteriorly outside of the incisura fibularis, and it gets stuck and it cannot be reduced. So these require surgery. Very rare, but if you're an auditioning medical student, this is a good term to know. You may be asked it, and it looks good if you've seen this before, especially starting out. And then finally, open fractures, which it's common sense, so we'll move on. And lastly, complications and other considerations when it comes to ankle fractures. Wound problems are fairly common. You have poor vascularity and blood supply in that area. The soft tissues are thin and stretched a lot, and then the hardware, puts a lot of stress on the soft tissues. So wound problems are fairly common. Deep infections are not super common, but you have to be concerned, especially in diabetic patients where the rate increases drastically, again due to poor neurovascular function in diabetic patients. Something you may be asked is neuropathy raises the complication in diabetic patients more than any other factor. And diabetic patients require enhanced fixation techniques, whether that's quadricortical syndesmotic fixation with multiple syndesmotic screws or external fixation. They just need to be stabilized more, and they should also be non-weight bearing 2 times longer than most patients post-op. Malunion is a significant complication, especially if you do not fix articular impaction of the tibial plafond, which I mentioned is a characteristic of supination adduction injuries. And finally, post-traumatic arthritis can be a significant complication, especially if you have a significant degree of talar shift. Just 1 millimeter of shift of the talus leads to 42% decrease of tibio-talar contact. So you end up with a lot of bone on bone, and this is the result. So that's why you want to get a good reduction. You want to reestablish the length of the fibula, and you want to stabilize the syndesmosis to keep the talus in its good anatomic position. So that's all I have for ankle fractures today. The next video I'll be discussing pelvic fractures. I'm going to keep posting these videos every day. As we go, I'll go into more detail. I just want to start basic now for quick refresher on classifications and radiographs and things like that. And then we'll get more and more advanced as we go. Feel free to post if you have any questions. If you're an auditioning medical student, you want advice, be happy to help out. Hope you enjoyed the video. Until next time, guys, have a good night.